Hello, and welcome to today's webcast, The Management of COPD, Exacerbations in Older Persons. This is part 2 of 2. I'm McKnight's Long-Term Care News Senior Editor Elizabeth Newman. Thanks for joining us today. Those of you who joined us last month learned how COPD is a common disease in older individuals. It needs a vigilant diagnosis and care. It's preventable and treatable, but COPD can be one of the most painful conditions to observe in your residence. Now, if you missed part 1, it's available on demand via mcknights.com/April 9th webinar. But even if you're jumping in cold today, the second part of our 2-webinar series on COPD will allow you to learn how to better manage it for your residents. That info is going to come from Todd King, the Senior Director of Clinical Services for Long-Term Care for Omnicare, a CVS health company. He'll jump in soon, but first let's make sure you have the info you need to get started. Slides are not available for download today, but the presentation will be available for reviewing for first-timers shortly after it ends. You can go to mcknights.com/May21st webinar. Now, if there are audio problems, please click on Test Your Connection. Note there is no call-in number, and if you have problems with echo, please try to eliminate multiple browser windows. Now, we'll have time for a Q&A session near the end of Todd's presentation. If you have any questions, you can submit them starting now or at any time during the webinar. Now, regarding the CEs, this educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. However, you must stay tuned into this event for its entirety during the original broadcast in order to receive a certificate. All licensed long-term care administrators seeking CEs must provide their NAB CE registry ID number in the webinar registration form. McKnights cannot verify or report attendance to the NAB CE registry without this information. For more information on that, visit nabweb.org/CE registry. You will also need to answer 2 confirmation questions during this live webinar to achieve your certificate. We'd like to note that this program is made possible with support from Omnicare. Please visit them after the presentation at www.omnicare.com. Now, it's my great pleasure to introduce our presenter. Todd King serves as the Director of Clinical Services for Omnicare. He manages consultant pharmacists and clinical managers. He implements clinical programs and manages the facility formularies while providing education for staff and customers across the United States. But Todd, before we dive into the exacerbations of COPD, what's one big takeaway that you want people to know that we learned last month?
Thanks, Elizabeth, and good morning, good afternoon, everyone. We appreciate you joining the call today. I think the one thing that we talked about, and it'll ring through this presentation also, is that the management of COPD and the management of COPD exacerbations is truly an interdisciplinary activity. It needs to include nursing, pharmacy, physicians, the patient, the family members, etc., because it is such a complex condition. We'll talk a little bit about that today and kind of go through some additional things that we learned last month around this process, the assessment of COPD, especially when exacerbations are occurring or potentially have the opportunity to occur. So I think it's a similar takeaway today that we had last month in the first presentation. So thanks for that, and looking forward to talking with the group.
Great. If you're ready, Todd, why don't you take it away?
Great. Thanks again, Elizabeth. So as I mentioned kind of briefly in the introductions, I'm excited about this presentation because it follows up the presentation that we did last month, and where we went through COPD, its management, non-pharmacological interventions, pharmacological interventions, and looked at opportunities to help maintain those people with COPD at the highest quality of life that they have. And unfortunately, no matter how hard or how diligently we work at that, there are opportunities and situations where these folks may actually have what we call an exacerbation. And we'll talk about that and define that as we go through the presentation. As I mentioned at the introduction also, it is important to remember that we will involve and talk about the involvement of the whole healthcare team in this process. Because once these situations or exacerbations are identified, the prompt and aggressive management of those can help these residents not further progress to ultimately what the the ultimate result of these exacerbations can be is a hospitalization, or even leading up to respiratory failure, and we'll go through that also. In this age and time of trying to prevent unnecessary rehospitalization, COPD is one of those questions and one of those conditions that really does make us look at this whole process and make it an interdisciplinary process. So we'll talk a little bit about medication management of these exacerbations, but also some non-pharmacological interventions. I always like to talk about non-drug things, even though I am a pharmacist. So in the first slide here, we're going to talk about the definition of an exacerbation. We're going to look at signs and symptoms of a COPD exacerbation, identify appropriate treatment options for acute exacerbations of COPD. A lot of the stuff, or most of the stuff that we will talk about today, come directly from the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD Guidelines. We talked extensively about the GOLD Guidelines in the first presentation, and we'll use the guidelines also in this presentation to discuss exacerbations and how they should be managed. So I really would encourage everyone that you really do go out and take a look at those guidelines, because albeit we have a lot of information in these slides, there is a lot of additional information that can be learned by going through those guidelines. So I would encourage everyone to make sure that they do have a copy of that. So let's look at this slide. Before we talk about specifics about exacerbations, let's step back and kind of look at our first presentation again and just go give some definitions. I think we ought to look at some basic aspects of COPD. First, it is a progressive condition and therefore it has no cure. A fundamental goal of the treatment of COPD is to keep the individual stable. In other words, to prevent further exacerbations that can permanently worsen their condition. But the fact remains that the exacerbations of COPD are very common, and when they do happen, the resulting deterioration usually results in additional treatment and modifications, including both non-pharmacological and pharmacological interventions. And I want to really kind of focus in on the last box here. I think this was a comment that I made in the last presentation that I think is important for us all to remember. In this day and age of us looking at trying to minimize medications, deprescribe medications in a lot of our geriatric patients, because we know so many of the medications out there that we use, such as psychoactive drugs and antipsychotics and those types of medications, really have potential hazards in our patients. It's important to remember that this condition, once somebody is stabilized, and you can see the comment there at the end of the box, reduction of therapy is rarely possible even after symptoms are controlled. So what happens generally with these exacerbations is someone has one of these, we reintroduce their old therapy prior to the exacerbation, and we learn that their condition has worsened because of the exacerbation, and we have to look at alternative therapies, additional therapies, etc. And we'll kind of walk through those today as we go through these and talk about some opportunities in some specific areas. So now that we've talked a little bit about some background and some reminders on COPD, let's talk about exacerbations and define them. The GOLD Guidelines defines COPD exacerbations as an acute worsening of respiratory symptoms that result in additional therapy. So there's that additional therapy. And keep in mind, when you say additional therapy, that does not always mean medications. It can mean non-pharmacological interventions also. Unfortunately, like a lot of things in medicine, the diagnosis of a COPD exacerbation relies exclusively on the clinical presentation of acute change in baseline for these two or three areas: shortness of breath, dyspnea, cough, and sputum purulence and volume. So changes in these three areas from baseline is what we're going to focus on as we go through a few of these slides to make sure that everyone's aware of how we can recognize these symptoms, because once we recognize these symptoms, the way that we act and the quickness and the promptness that we act really can affect the outcome for the patient. So these are key identifiers that we need to make sure, whether it's in a nursing home or an assisted living facility, or for those of you who work with independent living residents, maybe in a retirement type community setting, looking at that change in condition and promptly and aggressively addressing that with the medical team can really help reduce the severity of these exacerbations, and then also in the future hopefully prevent them. So this slide actually goes through and shows us how exacerbations can be defined by their severity. And when you look at the mild, moderate, and severe that are listed on this slide, I kind of broke these out based on the management of these conditions, mild, moderate, and severe. And keep in mind, as I mentioned in the previous slide, the prompt notification of the physician of worsening symptoms may prevent a mild or a moderate exacerbation from progressing to a hospitalization. So the goal here would be is if we recognize a change in that resident or patient, i.e. more cough or more shortness of breath, if we quickly identify that mild exacerbation, we can treat it with the actual medications listed here and be able to have a positive outcome. So when we look at these from a mild standpoint, most of the time these types of exacerbations can be managed with short-acting bronchodilators, things like albuterol, levobuterol, those types of products. Moderate conditions or moderate exacerbations require short-acting bronchodilators plus antibiotics and or systemic corticosteroids. Severe exacerbations can be associated with respiratory failure and generally requires a transfer to an acute care facility. You'll notice in this slide here an asterisk besides corticosteroids. I always like to point out the asterisks on these slides just because I think they are important, and we'll talk about this a little bit later. But the asterisk does say with corticosteroids, the duration of therapy should not exceed 5 to 7 days. So kind of everybody keep that in the back of your mind, because as we go through and talk about the management of these chronic, of these exacerbations, we'll talk about why that's important. People who have 2 or more exacerbations within a year are labeled as frequent, and those folks are more susceptible to hospitalizations, et cetera. So the way that we can reduce these exacerbations, and that's important for the quality of life for those residents. So for the rest of the presentation, I'm going to kind of use this graphic to show what we're going to go through the process of detection, treatment, and prevention of exacerbations as we go through. And we'll use this to kind of talk about some of the key principles that we touched on a few minutes ago. This slide does go over some conditions that may mimic or aggravate exacerbations, and these all make sense to everybody on the phone. Pneumonia, naturally, a pulmonary embolism, heart failure, cardiac arrhythmias, pneumothorax, anxiety, and depression. These types of things can naturally consider these other conditions and what's happening with the resident when we see COPD symptoms and challenges. Now, this is a pretty important slide, and we'll spend a few minutes on this, and this is the slide that covers the assessment for new and worsening shortness of breath and what some of those signs and symptoms are. And remember, as we've kind of touched on this, these key indicators here are really the opportunity for us to promptly address these changes in the person with COPD. So when we look at these, we really want to make sure that we're quick to assess these and we understand these conditions and these changes. Many times this information should be collected, and when a prescriber is notified, they should be notified in facility policies and procedures, algorithms, or support tools, because lots of times when you see something like a apical pulse of greater than 100 or less than 50 and a respiratory rate of greater than 28, that should stimulate a process to make sure that we're going through and looking specifically at ways to address this shortness of breath. Because we're talking about early detection, it's once again important as we talk about these signs and symptoms, and we're going to kind of go through those and just touch base on what we think are important in certain specific areas. A temperature greater than 100.5, potentially indicating an infection. As I mentioned, apical pulse greater than 100 or less than 50, a respiratory rate greater than 28 or less than 10, blood pressure changes less than 90 or greater than 200 systolic. OSATs are a great way to look at specifically how the person is exchanging oxygen, an OSAT of less than 90%, or one that is noted in a care plan that may be a standard for that resident. The use of accessory muscles. I think those of you who've ever had kids, when you take a child to a pediatrician and they're having a difficulty with breathing, that's something they always look at is accessory muscles. In the elderly population, that's an opportunity. It's probably not as good as a diagnostic tool as it is in kids. Cyanosis, peripheral edema, those are signs and things that we should be looking at for any time a resident has new or worsening shortness of breath. And then symptoms, we talked about this already, increase in cough, increase in sputum production, changes in sputum color, green or brown sometimes can indicate an infection, abnormal lung sounds, a change in mental status. This is one that seems to pop up in so many symptoms of geriatric conditions is a change in mental status, and this COPD exacerbations is really not different. And it is one of those areas where there's a couple things in here that overlap, and you would think about other conditions. Change in mental status naturally can lead you down a path of a variety of conditions that we deal with in our geriatric population. Difficulty sleeping. Naturally, if you're having trouble breathing, it is hard to sleep, and a lot of COPD patients deal with problems with sleep anyway, but sometimes in a potential exacerbation or shortness of breath, they will have more difficulty sleeping. And sleeping medications in these folks are really not good because they can alter the breathing process anyway. New or worsening chest pain. As you can imagine, the shortness of breath can cause some of that discomfort in the chest, and lots of times this is confused with cardiac issues and that type of thing. So these are some signs and symptoms that I think we all need to take into consideration when we see somebody having a new or worsening shortness of breath, because these can take you down all kinds of paths. And I think that's why it's important, as I mentioned at the beginning, it's important for the facility or the community to have policies and procedures or use algorithms or things like that to kind of triage these patients to make sure that we're getting that information to the prescriber as quickly as possible. And as I've reiterated that several times today, that I think it is important to make sure that we do act promptly and we act aggressively in managing these conditions. There's our slide again. So let's talk about the prompt treatment of exacerbations. And we'll spend a few minutes here just talking about some of the specific opportunities and the utilization of medications. We'll touch on a couple of these as we go through. In prevention, we'll talk about some non-pharmacological interventions. Okay. Oops. Sorry. So on this slide, we see the most commonly used medications for acute treatment of COPD exacerbations. We've already touched on the short-acting bronchodilators. This is albuterol with or without ipratropium. We'll touch on that in just a second. Oral corticosteroids, and then antibiotics. And when you look at the GOLD guidelines, it does state that about 80% of exacerbations outside of the hospital use these three drug classes to manage exacerbation. So I think it's good for us when we see these to have a really good understanding of how these drugs should be utilized throughout the process of an exacerbation. Okay. Now, as the last presentation that we did, we talked a lot about maintenance therapy. And, in maintenance therapy with COPD, we recommended using the long-acting agents. And that makes sense, right? Because we are maintaining a condition and hopefully preventing it and stabilizing it as we go forward. In the management of an exacerbation, we lots of times look at short-acting agents or short-acting bronchodilators. So let's look at these, and we'll go across these as we speak. Let's talk about the inhaled short-acting beta agonist or short-acting beta agonists, which include albuterol and levalbuterol, which is, that is Xopenex, and Ventolin is albuterol. These medications relax bronchial smooth muscle. They have common side effects that are listed in the slide here of increase in heart rate, tremor, and insomnia. These drugs tend to provide a very rapid symptom relief. As they open the lungs up for someone who is short of breath, it does resolve that situation pretty quickly. In the second box, we'll talk about inhaled short-acting anticholinergic agents. You know these medications as Atrovent. Sometimes these are referred to as muscarinic antagonist, or in this case, short-acting muscarinic antagonist. They have a slightly slower onset than the short-acting inhaled beta agonist, but they can be used for those people who cannot tolerate the short-acting beta agonist. So some people really have challenges with the increase in heart rate with albuterol, or even levalbuterol for that matter. So I think that's an area where the anticholinergics or the muscarinic antagonists can be used. These drugs do have similar anticholinergic side effects that we see with the oral medications, because as you think about it, as you're inhaling these products into your lungs, they are going into the bloodstream. So you can see urinary retention, dry mouth, acute glaucoma if it's sprayed or nebulized directly into the eyes. And believe it or not, I have seen that happen in several situations over the years, where either inadvertently a resident with that have dexterity challenges actually spray the inhaler in their eye, or a nebulizer product be put directly into the eye inadvertently, and it really can cause some problems. It really can cause some problems with glaucoma or changes in intraocular pressure. So that's one of the things to consider with these drugs. I do think when we look at the peripheral anticholinergic side effects, urinary retention and dry mouth, those are problematic in the geriatric population also, because we do use a lot of medications that alter that cause dry mouth and that can cause urinary retention. So it is something to kind of take into account. So when you look also, some people do respond a little bit better to the combination products. So you'll see here I've listed the combination inhaled short-acting beta agonist and short-acting anticholinergic drugs. And you guys know those as Combivent or Duaneb out there in the marketplace. Some people do get, as I mentioned, better benefit from the combination drugs than just the single drug in its own entity. So first, as we touched base on from the previous slide, was short-acting bronchodilators. These agents, just as a rehash real quick, can be used to provide rapid symptom relief in someone who is having shortness of breath. They've been shown effective. They do have side effects that we need to kind of keep an eye on, especially with the beta agonist. The increase in heart rate is sometimes a problem. Insomnia, and as we mentioned earlier, these folks already do have challenges with insomnia without their medications based on their condition. So the next one, let's touch base on the oral corticosteroids, and I think this is a real important slide. The corticosteroids do have an important role in the management of COPD exacerbations because they both improve symptoms and lung function, which is important. And they do also decrease the risk of early relapse. So I think that's important to keep in mind. We should really not confuse this with the chronic daily oral administration of corticosteroids that we see sometimes. You may see somebody with chronic COPD who is on a prednisone 5 milligram dose daily and has been on it forever. Lots of times the data shows that that's really unnecessary, and that we should manage those patients with inhaled therapies because of the risk and complications and side effects of long-term oral steroid use. So I really think it is one of those things that we should really differentiate and make sure that we're aware of that. When used appropriately for 5 to 7 days, oral corticosteroids have been shown to have a positive impact on COPD exacerbations. And I think that's an important factor for us to remember. Usually what's recommended is a prednisone 40 milligram or equivalent dose of an alternative steroids, corticosteroids that should be given for no more than 5 to 7 days. In that time frame, you still can see some of the side effects of steroids, and that can be, any type of mild mood changes, all the way up to psychotic type symptoms, bleeding, hyperglycemia, mood swings, etc. So some people do, in certain situations, do think that the 5 to 7 days is really not something we should be worried about from a side effect standpoint. But remember, in a geriatric patient who has multiple medications, who have multiple chronic conditions, we really need to look at that and make sure that we are aware that some of these side effects can come out even in that short duration of therapy. So I think that is an important one for us to remember, and just make sure that we look at the specifics around those potential side effects and educate our nursing staff on. And the people who have COPD, they'll tell you, and they know what side effects they have from steroids, and they can tell you, especially if they've been on multiple courses of steroids over their lifespan, they can tell you what happens. They'll tell you that, yes, it makes me very anxious, or yes, it makes me jittery because my glucose goes up. So they know what to expect when they take those drugs. And once again, that's a good opportunity for us as caregivers to really interact with that patient, to talk about their experience with these medications and what their experience is during an exacerbation. So I think that's a great opportunity around the management of COPD and COPD exacerbations for us to have an involvement in that process, is to listen to the resident and actually let them tell you what the expectation is going to be when they take these medications, even for that short period of time. So the third bullet that we had a minute ago in our treatment cascade for the most common medications used to treat exacerbations were antibiotics. And, you know, in the age of antibiotic stewardship and the time that we're looking and focusing on appropriate use of antibiotics, this is a great slide, I think, to really kind of give us some insight on when these drugs should be used for COPD. And really, they should only be used when there is a bacterial infection that is present, and that can be noted with clinical signs and symptoms of that bacterial infection and appropriate documentation, as you can see here. So generally, these antibiotics, like the steroids, are given for short courses, 5 to 7 days. And here's what, as you can see in the 3 boxes here, these patients who have the 3 cardinal symptoms, increase in dyspnea, sputum volume, and sputum purulence, or have 2 cardinal symptoms where increased purulence is one of the 2 symptoms, and or they require mechanical ventilation, which is invasive or non-invasive. So this is an area where we'll choose to potentially use an antibiotic based on the symptomology of what the resident or the patient is presenting. And the 2 cardinal symptoms, naturally, as we mentioned, is change in that sputum, and then the other, shortness of breath and sputum volume. Important factor to remember, too, is that change in sputum color can naturally indicate an infection, and it's important to remember that that's a process where we want to make sure that we use antibiotics judiciously and with appropriate therapy. Now, there is a certain patient population who, after the recovery from an exacerbation, you may see a long-term antibiotic for former smokers at high risk for exacerbations when optimal inhaler use is not enough. So you may see in certain situations where a prescriber may use a macrolide antibiotic like azithromycin for up to a year to prevent recurrent exacerbations. And this is a condition where, you know, we need to look at the risk versus the benefit, and also look at local resistant patterns and recent antibiotic use when we're considering treating somebody long term who really would need to be appropriate utilization. So this is an area where when you look at the GOLD guidelines, you can go a little bit deeper into when these long-term antibiotics might be used, specifically in those folks who are former smokers. So just keep that in mind with antibiotics. I think, you know, we, in the age of antibiotic stewardship, we should have, once again, as we talked about algorithms and things in our communities, to make sure that we are following processes that are according to standards of practice and standard of care. So the GOLD guideline would be that standard, and they do outline in there about the utilization of this long-term antibiotic in someone who is a previous smoker. So now let's touch on prevention. And I think this is an area where, as if you guys have heard me speak before, preventing a lot of the situations that we talk about, whether it be behavioral symptoms in dementia or exacerbations in COPD, it's important for us to have know the risk factors of the exacerbations and what occurs with that condition so we can help prevent it. And the next slide kind of goes through those. And I think this is a nice slide to kind of give us an opportunity to look at prevention, because the key part of prevention is awareness. And I think we should look at these risk factors for exacerbations. It's important to realize that the most common cause of an exacerbation is a viral or bacterial respiratory tract infection. But as you can see from this slide, is about a third of the severe exacerbations that happen, we don't know why they happen. So it's important to remember that, albeit we know that the most common cause is bacterial or respiratory tract viral or bacterial respiratory tract infections, but the other third of these we really don't know, and they can happen with any of these other areas that are listed here. So I think that's important for us to be aware that we should look at other risk factors which could be controlled, such as smoking cessation, immunization against viral illnesses, early identification or worsening of symptoms, and also ensuring adherence and proper utilization of COPD maintenance therapy. So when you look at these, I think it's important for us to be aware of these. So delayed recognition of worsening symptoms, as we've touched on earlier, the prompt identification of shortness of breath changes and increase in shortness of breath is important for us to make sure that we look specifically at those opportunities to reduce that risk. Advancing age, frequency and severity of prior exacerbations, interruption of maintenance therapy. We think about that. If you're in a nursing facility, there really shouldn't be interruptions in maintenance COPD therapy. But as you go into other environments, such as assisted living and independent living, I think it's important for us to not forget that there may be situations where the resident is not getting the medication, whether it's because they can't appropriately use the medication, or in some situations they can't afford it. The drugs that we're talking about are really expensive, and that is a situation that we really need to kind of keep in mind. If you're in a retirement community setting where there's independent living residents and you have a previous smoker who is a previous smoker who quit and they're on these medications, and they start getting worse or they have a problem with shortness of breath, etc., that's one thing that should always be considered. Maybe the first thing is, are you using your medication correctly? Do you even have your medication? And making sure that the resident is not, the exacerbation is not caused by an interruption of therapy. Other comorbidities such as GERD, heart failure, pulmonary hypertension, thromboembolism are risk factors for acute exacerbations. Exposure to air pollution. There are certain parts of the country where there are situations where there are air pollutants that can cause exacerbations. Certain types of chemical plants, paper mills, those types of things are areas where we need to be really careful about knowing the history. If that person actually worked in those settings or exposed to those types of settings, they can be at risk for acute exacerbations. So here's a couple other slides, just some other prevention of additional COPD exacerbations. It's important to really make sure that we reevaluate the maintenance therapy, as I talked about. Some of these considerations that we see here is if someone is resolved from an exacerbation, we need to make sure, as the symptoms improve, that we reintroduce maintenance inhaler therapy with long-term or long-acting bronchodilators as soon as possible, and escalate that therapy based on disease severity. And that means, there are certain situations where the exacerbation is so severe that the resident really has to stop using their inhalers, et cetera, till they can get the exacerbation resolved. With the short-acting agents, we should make sure we reintroduce those maintenance therapies as quickly as possible. Evaluate the need for other maintenance therapies such as oxygen, other drugs like Dilaresp or macrolide antibiotic, address the potential for additional pulmonary rehabilitation. This is becoming a higher opportunity for us in long-term care to make sure that we're looking at pulmonary rehabilitation in certain situations. I do think with the aging population increasing and the number of people with COPD coming into our facilities, is important that we do have that type of rehabilitation. And then naturally, as we touched on just on a couple slides ago, is to assess the ability to properly use all prescribed inhaler devices, I think is extremely important. Because when you look at it, and we'll talk about this kind of towards the end when we talk about the appropriate selection of certain types of inhalers, it's very important that we can have all the right drugs out there, and we can follow the gold guidelines to a T. But if the resident can't utilize the devices, then it all goes for nothing. So we'll touch on that in just a few minutes. So this next slide looks at the reintroduction and follow-up pharmacological management of COPD when exacerbations are a concern. And this comes straight from the GOLD guidelines. As you can see, this actually goes through and walks through specific how we do reintroduce inhalers and reintroduce maintenance pharmacological therapy. Additionally, some individuals will require that their maintenance therapy be advanced to decrease the likelihood of future exacerbations. Please note where you see on this slide where the addition of Dilaresp or Roflumilast, azithromycin, and the relatively new use of an eosinophil count fall into consideration. We touched on all this at the first presentation that we did as far as looking at the use and escalation of drug therapy throughout the GOLD guidelines. Does have some new introduction of some new opportunities around utilization of eosinophil counts to consider the use of certain products. Once we get into the medications used for more severe disease, we need to carefully tailor the regimen to the patient's clinical profile. For example, not everyone will benefit from an inhaled corticosteroid, and continued use may increase the risk of pneumonia in other types of situations. So this slide just kind of goes through making sure that once somebody has gone through and their exacerbation is over, and or we are concerned about future exacerbations, we really should modify for persistent symptoms with or without shortness of breath. So another thing on the key right-hand side here is making sure, as we've touched on again, and we'll touch on the next slide, is to assess inhaler technique and inhaler compliance and look at specific opportunities for us to use those products. And then naturally look at external causes, look at infection, and also look at smoking cessation. And, as we touched on in the first presentation, smoking cessation is the one disease modifiable activity that we really need to make sure that all of these patients or residents go through, is to make sure that smoking is stopped to prevent all kinds of complications with the condition. So this slide and the next few slides that we go through, we'll talk about some of the specific opportunities around looking at product selection. We've kind of been through the appropriate use of drugs in specific exacerbations. We've talked a little bit about some of the opportunities around utilization of step therapy or escalating therapy based on the clinical condition. But let's just try to look at specifically some considerations for product selection. We want to match the product to the severity of the disease and the individual ability to adhere to the therapy. So we try to utilize inhalers with similar administration mechanics, match the device to their dexterity, abilities, and preferences. Consider the impact that multiple inhalers may have on compliance and acceptance. We talked about cost a few minutes ago. Also, administration time. I think it's important to remember, if you've got a person who takes two or three inhalers 3 or 4 times a day, that's pretty much their whole day is administering those devices. And sometimes people just are not able to adhere to that type of therapy. So I think it's important to make sure that when we look at inhaler therapy, that we look at specifically, what type of product we should use. A metered dose inhaler, those are the MDIs or metered dose inhalers. They often require more dexterity and a slow, deep inhalation, whereas a powdered inhaler may necessitate more of a rapid inhalation or an actuation. So these inhalers do work differently based on their mechanism and based on the actual product that they have. So selecting devices that have similar set of instructions can reduce confusion and make sure then that the resident's not using improper technique. The other thing to consider, and there's a lot to consider with these inhalers, how involved is the cleaning process of the inhalers? Will combination products be more convenient and acceptable to those who are often outside of their room or outside of the facility or go out frequently on day trips, etc.? Better acceptance will improve adherence and hopefully improve outcomes. So I think, making sure we kind of keep all those types of things in play to make sure that the resident is able to use that product and it is convenient for them in their daily activity. So when you think about it and you think about the comments that we made on that slide, there may be a person who is in a nursing facility who is not as mobile as somebody in an assisted living facility. You may tailor your therapy based on their ability to ambulate, if they go out frequently and take day trips, etc. I think that's an important thing to keep in mind. And once again, as we talked about at the beginning, a specific opportunity for us to be interdisciplinary with this process. We have nursing and pharmacy and the docs and social services and everyone involved in the process to make sure that these folks are having the best outcome that they can have. We would be remiss if we did not touch on vaccines, and I think as we talked about in the first presentation, for people who have COPD, vaccines are very important. This is something that I think we should consider in all of these residents, and as you know, the data is out there. Specifically, respiratory infections are the leading cause of exacerbations in COPD, so it's important that we review the vaccination history as part of our preventive program. The annual flu vaccine can reduce serious illnesses such as lower respiratory tract infections that may require hospitalization, even death in those with COPD. Likewise, both pneumococcal vaccines are recommended for older adults, and the pneumococcal vaccine is also recommended for younger individuals with COPD. It's important to remember that those two are key vaccines, and now we often talk about those two. We don't often talk about the third vaccine in this slide, which is pertussis. Pertussis, or whooping cough, is associated with exacerbations of both asthma and chronic bronchitis. And with the resurgence of pertussis cases in the United States, we really should have a one-time tetanus, diphtheria, and pertussis vaccine in place of the every 10-year tetanus, diphtheria boosters in those adults who we do not have evidence of being fully immunized as children. So I think this is an important thing to keep in mind, especially as you think about it. Those COPD exacerbations can happen at any time, and we talked today about environmental causes. We talked about just changes in lung function, etc. These are three preventative vaccines that can actually help reduce those respiratory type infections that can lead to exacerbations. So I know we've talked several times in these webinars about conditions where vaccines are used, and this is no exception. So make sure that history's done. We do have some regulatory requirements around influenza and pneumococcal. Make sure that we do follow those opportunities in skilled. Now, in assisted living and independent living, making sure that we do a history when that person's either moves into the community or when we do their health screening, that we look and see if they have had these vaccines in the past. And naturally, we should have a program in place to make sure that everyone gets the influenza vaccine at the specific time of the year it's recommended by the CDC. So just to finish up here, I just want to give just a quick close on this, and I really hope that today you have an appreciation now of what all we can do to help prevent COPD exacerbations. And this slide kind of sums it up. I've touched on the vigilant monitoring for early warning signs by the entire interdisciplinary team. And as we've talked about earlier today, the interdisciplinary team is a key process of how we can make sure that we identify symptoms quickly, we make sure that we communicate those with the prescriber, et cetera, and start the process and the cascade of treating these exacerbations if they occur. Establish clear parameters when the prescriber should be contacted with things like algorithms, and those types of things are very beneficial to utilize step processes and make sure that we are looking at specific opportunities on when the prescriber should be engaged. Routinely encourage smoking cessation, manage comorbidities, and initiate preventative measures. We went through some of those today, and we talked a lot about some of those opportunities. Ensure compliance with maintenance COPD medications. There's so many inhalers out there on the market, and they have different processes and different ways and techniques to use them. This is a key opportunity for us to really look at situations where we can get a good information on how we can properly use these products and properly evaluate these products and move forward with those specific inhaled devices. So it is really important for us to keep those in mind, that we utilize those appropriately. So with that, I'm going to turn it back over to Elizabeth, and those are kind of my comments for today. I really appreciate you guys taking the time to be on the webinar. And, as we touched on at the beginning, and I've said throughout this, the interdisciplinary process is key when we really want to make sure that we're processing and moving through the whole management of this condition, not just exacerbations, but management of the chronic therapy also. So, Elizabeth, I'll turn it back over to you for your closing comments. Thank you.
Well, thanks, Todd. This information is great and very helpful to our audience. We do have some time to take a few questions if you want to type those in now. But let's start with our first one, which is why do some physicians order both Advair and Spiriva together for one patient, Todd? Is there a treatment for all three symptoms that you can recommend?
Yeah, I think what you see is you're looking at three different categories of drugs there. So you've got a bronchodilator, a steroid, and then a muscarinic agent. And when you look at the GOLD guidelines and you look at the specific opportunities and the escalations of those processes, there are recommendations in those areas where specific you escalate based on the symptomology. So some people do need the beta agonist and also a inhaled steroid, and then also antimuscarinic agent. So that is pretty much a common therapy. Now, we do have some newer therapies on the market. There's a triple therapy out there now where you can get the three medications in one inhaler. For some people, that's a good opportunity where compliance to the medication or compliance to the inhaler may be a situation where someone might want to not use two inhalers. Keep in mind you've got to keep in mind the cost factor and insurance coverage and those types of things, because all these medications are very expensive.
You mentioned bronchodilators, and one of our participants wants to know if you think the cost of the bronchodilators contributes to the return visits to the hospital when they can't afford treatments. Do you have assistance programs that you may recommend for residents who are in that situation?
I do think, when you look at this condition, it's not just the bronchodilators, but when you look at this condition, adherence and compliance to therapy is a huge challenge. And we could spend probably a whole nother webinar going over, the different types of inhalers and the different types of devices and how they're used and that type of thing. So I do think that, unfortunately, in our industry, that has created some of the challenges that we see with hospitalizations, et cetera, is compliance and adherence to therapy. As far as programs for those people who can't afford their medications, some of them, I would encourage the group, if you have a situation out there where someone needs the treatment and they need the medication for maintenance and therapy, et cetera, they can reach out to the manufacturers. Some of the manufacturers do have compassionate programs or compassion care programs. There are some states that have those also for people who so I would encourage the person asking the question to kind of reach out to the local area to see if there is something from a state standpoint, and then also the manufacturer.
Great. You talked a little bit about anxiety and depression being an issue for some people with COPD, and of course there's some pressure now to start reducing those medications for people who are being treated for anxiety and depression. What is your advice for managing that tapering for people who are also dealing with COPD?
I really like this question. I wish we had a little bit more time to talk about it, because when you look at the management of anxiety in people who have COPD, first of all, let's be honest. When you can't catch your breath, it does create anxiety. There are some of these people who do, because of that sensation and that fear, are treated with medications to help their anxiety, like benzodiazepines and those types of things. Those drugs in themselves affect respirations. So it is, in a lot of cases, worthwhile to try to wean the person off of those medications. And, I think it's a good clinical practice, because, there are a lot of other side effects that come along with the benzodiazepines, and we all know those. There are falls and incontinence and confusion and those types of things. So I think it is a good situation where you should try to gradually reduce those products. The answer to the taper is, I don't really know. And the tapering question is something that I think is really, it's important to decide for the clinician what the appropriate methodology is to taper. But some general guidelines are, with a short-acting benzodiazepine, 25% of the dose over a 2 to 3 week period is generally considered. What you'll see out there is some recommendations. Some people are required to go slower. Some people you may be able to go faster. Keep in mind, the benzodiazepines, and these are the drugs we're talking about, Ativan and Xanax and those types of medications that are commonly used for anxiety in folks with COPD, are addictive medications, and they do have a withdrawal type syndrome that can occur. So tapering is a necessity, and I think it's one that just needs to be carefully individualized for that resident. CMS guides us that we should be doing resident-centered care, and the reduction of psychotropic medications and the reduction of these types of medications should be a patient-centered approach, and it should be individualized to each person. I hope that answered the question.
A wonderful answer. Now, finally, one person wanted to know, they know you touched about antibiotics in the first webinar, but can you just review the antibiotics that are most commonly used for when there's an exacerbation of COPD?
Yeah, generally those are going to be the antibiotics that hit those respiratory organisms, generally the macrolide antibiotics. I mentioned the one azithromycin with Zithromax. Can't say that too fast 3 times, but that is one that's commonly used, the macrolide antibiotics, because they do hit those organisms that cause upper respiratory tract infections. Those are the ones you'll see most commonly used. And once again, I think it's important to reiterate, with antibiotic stewardship, we really want to make sure that we're using short courses of therapy, except in that situation where I mentioned someone that, has frequent exacerbations or past smoker who may benefit from a long-term treatment of a macrolide antibiotic. But I think if we use those drugs judiciously, we can avoid resistance and avoid having to use more powerful medications down the road, because that's the last thing you want to do, is to have someone who's repeatedly given long courses of antibiotic therapy and then they wind up in the hospital because they need an IV antibiotic now because the everything's resistant to the oral agents, and they wind up in the hospital. So our goal with exacerbations, as we touched on earlier today, is to make sure that mild to moderate does not go to severe. And if we can appropriately use the drugs that we talked about, that's an opportunity for us at the end of the day to really reduce those exacerbations and hospitalizations. So that's the most commonly used antibiotic.
Well, great. Todd, any final thoughts for people that you want them to take away from today?
No, I think we've kind of touched on it at the beginning. As this is an individualized process that has to be interdisciplinary. Each patient is going to be an individual, as we know, and their drug therapy and their non-pharmacological therapy needs to be tailored to their abilities to manage and use these devices that are going to help them breathe. And I think that takes an involvement of the nursing staff or the pharmacist to educate them on the use of these devices, the physician to be aware of the signs and symptoms and to know that resident and when to prescribe medications to prevent an exacerbation from going to a mild to a severe. So it does take a team, and I think that's with this condition, not only the maintenance therapy, but the management of exacerbations. That team needs to be close-knit, and they need to be working efficiently. And as we talked about earlier today, the prompt identification of this symptomology is so key to making sure that that person doesn't go, and I'm going to say it again, from a mild to a moderate to a severe and ultimately wind up in the hospital. Because we all know when our patients go to the hospital, they change and things happen to them. Not that it's the fault of the hospital, but it's just an acute situation that really does cause changes in them and really sets them up for potential problems down the road. So that would be kind of my take home, is to make sure that it's individualized care and we've got a interdisciplinary approach to each individual resident. So thanks again.
Well, Todd, this has been really wonderful information. And for all of our listeners today, we do hope that you enjoyed today's webcast. This session will be available shortly at mcknights.com/May 21st webinar. Again, a special thanks to Todd King for this insightful look at COPD. We've really learned a lot. And we'd also like to thank our session sponsor, Omnicare. Check them out at www.omnicare.com. Thanks to you, our listeners, for your listening and your excellent questions. And thanks for tuning in today. This has been Elizabeth Newman for McKnight's. We hope to see you again soon.